So my name is Dominique Ash, and I'm a nurse practitioner in preventive cardiology at Johns Hopkins, and I've been working in preventive cardiology for over 13 years now. And our goal is basically to help patients from 20s to 90s in the prevention of heart attack and stroke. So individuals who have never had a heart attack or stroke, we try to prevent them from ever developing that. And those individuals who've already had heart attacks and strokes, we try to prevent them from having a second event. So what I've done is I've taken what I have in my preventive cardiology toolbox and applied it to the firefighter population. And the reason why this is so important is because in my job as preventing cardiovascular disease, that's really something very important to apply to all firefighters, given that, as you well know, the #1 killer of firefighters is heart attack. So what I'm going to do today is present to you a study that we did with Baltimore County firefighters and Howard County firefighters. It's a small pilot study, but it's the beginning really of a way to view preventive medicine for firefighters. So in today's talk, I'm going to talk about 4 different things. One is heart attacks in firefighters, just in general. Then I'm going to go into a discussion of what cardiovascular disease is and what we mean by prevention. Third, I'm going to actually show you what we did in the study and present to you the study results. And then finally discuss what is really important, and that is developing a team partnership between firefighters and their healthcare providers to reduce firefighter deaths from heart attack. So let's start out. First of all, you're going to be seeing this slide of the 4 important points to remember, and we'll go through each of the points. The first one is going to be the concept that cardiovascular disease, and specifically heart attack, is the #1 killer of firefighters. So let's talk about that first. And of course, the headlines are very sobering. These are just 2 examples of deaths of young individuals that didn't need to happen. And very close to home too in terms of Baltimore County. It's very concerning. And when you look at the U.S. Fire Administration data, this is 2012, but it's clear that if you look at all the fatalities by nature of the injury, fatal injury, the largest percentage, over 48%, is due to heart attack. Stroke is much smaller, as you can see here, but heart attack is the main thing. And of course, heart attacks can occur at any time of duty, after an incident, on the scene of a fire, during training, responding. But I'll tell you a really important point to keep in mind is this, that through studies what they have found is that these on-duty cardiovascular events in firefighters occur almost exclusively in individuals who have underlying cardiovascular disease. That is, they already have atherosclerosis. They may not know it, but they already have it. So they're going into this very high-risk situation in their job with underlying disease, which puts them at even higher risk. So I think that's the important point here is if we have firefighters with underlying cardiovascular disease, it's important to identify them. So I'm going to show you how we're doing. That was the question, how do we do that? So we're going to get to that. As I say, I'm utilizing all the toolbox in our preventive cardiology, or I should say all the tools in our preventive cardiology toolbox to apply this. So, it's not just deaths, it's actual non-fatal events too. In my practice, I see people all the time that have had heart attacks and strokes, and they've survived them, but they've had untoward problems throughout their lives as a result. So not only do we want to prevent deaths, we want to prevent essentially events that people survive. We don't want to have them at all. So, one of the questions I always say is, so who are we going to focus on, and how do we focus on these individuals? And I think if you look, again, this is U.S. Fire Administration data, just focus on the beige columns here. And you can see, and here's the age, And we're talking about heart attack, stroke, other events. But you can see these start to really climb starting around 40s, and you can see how it exponentially increases. And so, and it makes sense. Think about the individuals you know that have had a heart attack. Generally, they're men. Generally, it's in about their 50s, right? 50s, 60s, right? So we're not too far off here. So essentially, yes, we really want to concentrate on individuals over 40. Because I'll tell you the truth, and we'll see this in a minute, that age is a very big driver for cardiovascular risk. It's a very big driver, and it's clearly one of these risk factors that you can't change. But you can also see that there's still risk less than 40. And the way I look at individuals less than 40, and as you are well aware, there's a huge population of firefighters less than 40. You are a young group of individuals. And people say, oh, well, thanks for, that's really nice, you think we're all young. I see people in their 80s and 90s. So yeah, when you're talking about people in their 50s and 60s, yes, this is a young population. Yes, sir.
The stats that you have on the bar graph, the one for 61 and over, does that reflect the people that are on active duty, or does that also encompass retirees?
It's hard to know. I don't know the answer to that question. But I will tell you, it's the percentage of having fatalities due to heart attack and stroke really is very high when you get over 60. So that's not too unusual a statistic to see, but I don't know if that data reflects retirees. I have no idea. The fact is that age is a really big driver for cardiovascular disease. But I also think of it too, is when you talk about people who are younger than 40, think about the cardiovascular risk factors that you can have as even a young person. I see people in my clinic in their early 20s that have really high cholesterol, and that's a big risk factor. So sometimes, depending upon what your genetics are, and your lifestyle, you could be developing risk factors for cardiovascular disease in your 20s. So the answer to the question is, who do you really focus on? And the key there is all the firefighters. Sure, your focus and your actions may be somewhat different in how you treat those who are younger than 40 versus older than 40, but the bottom line is you have to focus on individuals all throughout the lifespan. So let's step back a bit and talk about cardiovascular disease and prevention and kind of put this into perspective. Because really, in order to prevent heart attacks, it's important, and this is what we do every day, to identify cardiovascular risk factors and reduce those risk factors. That's what we do. So what is atherosclerosis? You hear these terms, hardening of the arteries, atherosclerosis. Atherosclerosis is just fatty plaque, and it really does look like this. It looks like fat. And you can see diagrammatically as it increases in a blood vessel that it reduces the amount of blood flow through that blood vessel, and it reduces blood flow to the target tissue on this end. It could be your heart, it could be your brain, it could be your legs. And so essentially atherosclerosis results in cardiovascular disease overall. And you can have atherosclerosis in your neck vessels, in your brain vessels, in your heart vessels, in your leg vessels. It could be everywhere. And I show this because it's really important to see how it progresses. Atherosclerosis progresses over a long period of time. It's very insidious. It can start off with a tiny streak in the inner lining of the blood vessel. And in fact, you can see fatty streak in individuals in their teens. So this kind of progression can start very early on. And it's a complex progression of events that involves inflammation, it involves fats, it involves white blood cells. But as you can see, as it gets more and more development of this plaque, there's a point in time at which the plaque can become unstable, it can rupture, and on the surface will be development of clots, and you can eventually end up occluding the entire vessel, reducing and completely stopping blood flow to the target tissue, and that's what results in heart attack or stroke. So this is this soft plaque that can rupture. But there's also what's called hard plaque or calcified plaque that you can see here. So when a person develops atherosclerosis, you can develop both soft plaque and calcified plaque. It takes time for the calcified plaque to develop, but you can have what we call heterogeneous plaque or atherosclerosis. I have a lot of my patients ask me, so where am I along this path? And I can't tell you. What I can tell you is that what we do in preventive cardiology is to prevent progression in this direction, to the left or to the right. And we're trying to prevent rupture of plaque, we're trying to stabilize plaque, we're trying to prevent clots from forming on top of plaque, we're trying to prevent progression in the amount of plaque over time, and we do that through risk factor reduction. So when we talk about heart disease, that's just fatty plaque or atherosclerosis in the blood vessels that provide blood to the heart muscle. So if you have plaque here and it reduces blood flow to the heart, you actually reduce the blood flow to tissue, thus the oxygen flow to tissue, and that tissue can die. So that's essentially can end up as a heart attack. And of course, you know the signs and symptoms of a heart attack. And you can also get this in vessels here, in your carotid vessels here that lead to the brain. And again, fatty plaque in this area here can reduce blood flow to the brain. You can also get fatty plaque in the small blood vessels in the brain as well. The general term for this is cerebrovascular disease. But again, it's all based on presence of this fatty plaque. And again, reduction in blood flow to the brain can result in areas of damage and thus stroke. So when we talk about preventive medicine in terms of cardiovascular disease, we really want to identify your risk factors, your risk for heart attack and stroke, and reduce those risks. So what we do is we look at each individual and we identify their cardiovascular disease risk factors. We'll go over the specifics in a minute. We also have over the years used what we call a risk calculator. It's a brand new calculator, and I'll describe this in a minute too, to find out what your 10-year risk of having a heart attack or stroke is. Then what we also do as part of our tools in our toolbox is we can actually try to identify if an individual has fatty plaque in their carotid vessels and their coronary vessels. And we do that through a CT scan and carotid ultrasound. And then what we do, based on what we find in 1 through 3, we develop an individualized care program for each patient. We work with them to identify their cardiovascular disease risk factors that need to be controlled, better controlled. We work with them on lifestyle habits and their weight, and we also prescribe medication when necessary. So this is our toolbox, so to speak. So let's go over those 4 pieces of a prevention mechanism that we utilize. So let's talk about risk factors. So you're probably very well aware of all these risk factors, but let's talk about some specifics here. Let's talk about those risk factors you can't change. So I've already talked a bit about age. If you're a man over 45 or a woman over 55, you're at higher risk. And if you have a family history of heart disease, let's say someone had a heart attack or stroke, or even went in for an open heart surgery or angioplasty and stent, in your father, brother, or son under 55, or mother, sister, or daughter under 65, again, that's considered a cardiovascular disease risk for you. And in fact, interestingly enough, if you have a sibling that has had some sort of event, under 55 as a male or under 65 as a female, that's even higher risk to you than if it was your mother or father. So knowing what your family history is a really important piece of the picture. Again, these are things you can't change. We have to really work on the risk factors you can change. So the 4 big ones are blood pressure, cholesterol, smoking, and diabetes. Those are significant risk factors that can either drive you towards cardiovascular disease, or when under control can really help us minimize your risk. But you can also add in there being overweight or obese, lack of exercise, poor dietary habits. But these are things that we can work on through lifestyle as well as medication management. And that's what we do in prevention. We kind of put them together. So in firefighters, there's been numerous studies about blood pressure as a cardiovascular disease risk factor, indicating that it is a very strong predictor of on-duty heart attack. Also, studies in firefighters with regard to obesity, another cardiovascular disease risk factor, indicates that firefighters are actually 2 times more likely to have thickened heart muscle, changes in their EKG, changes in their blood vessel structure, and actually having high blood pressure. So there are a lot of studies related to cardiovascular disease risk factors in firefighters. And in terms of the risk score, you can access through the American Heart Association or American College of Cardiology, calculating your 10-year risk of having a heart attack or stroke. It's actually for cardiovascular disease risk, and all you need to know is if you're on medicine for blood pressure, what your blood pressure is, what your total cholesterol is, and what your HDL cholesterol is. It's very helpful. The third one is looking for atherosclerosis. We can do that in 2 ways. One is the use of the CT scan. And the CT scan detects that calcified plaque that I described to you. And you can see that here. This is an example of what you would see. See the white? That reflects the calcified plaque. So this individual has quite a lot of plaque in multiple vessels here. This by far has the most data to support the fact that if you find calcified plaque in an individual, then that individual's risk of cardiovascular disease event is much higher than if you did not. Now, keep in mind, this is calcified plaque. This does not pick up the soft plaque. So, and since it takes time for plaque to develop, we generally don't screen individuals less than 40 with this kind of tool. But as I say, this is the tool of choice. It has a lot of evidence base for it. Yes, sir?
Safe to say that if you have calcified heart plaque, that there's going to be a lot of the soft plaque that's
well, not
going
a
to
lot,
be changing soon?
but this is a very good question. And so if you have calcified plaque, that means you have soft plaque too. Because you saw in that vessel, as I described it, really you're going to develop the softer plaque, which then over time can calcify. So yes, that's a very good question. So the concept is if you have calcified plaque, you have soft plaque, and that indicates you have a higher risk of cardiovascular disease event. Thank you, that's a good question. Yes, sir?
You talked about the heart CT scan and the carotid ultrasound. And is that something that we would normally get in our yearly physical, or is that something that we would have to specially request? And, is that a specialty test where we got to take care of it through our own insurance, or is it something that the department ends up picking up?
I think it depends upon each individual department. But I will say, in terms of the general picture, these kind of tests, and the one I'll just describe to you in a minute, the carotid ultrasound, these are tests that you can get through your primary care providers. But as I say, generally the test, they do the test primarily in individuals, at least this test for sure, 40 and up. Because the likelihood of finding it 40 below is fairly low. It doesn't mean you can't do it, but so, and it used to be that these tests were not even supported by American Heart Association or American College of Cardiology, but in the new guidelines, the American College of Cardiology, American Heart Association do recommend that these kind of tests can be done. So that's very supportive. So as far as insurance, I actually, in most cases in our clinic, most people have to pay out of pocket for these tests. And the price has really come down over time. This test can cost about $100 out of pocket. Used to cost 13, 14 years ago, over $400. So it's really changed. But I think the technology has changed too. It's much better much less, because radiation is involved in this, real minimal radiation involved. And so, but most people have to pay out of pocket. Although I heard just recently in another talk I gave that a firefighter said that his insurance paid for it. So I think it just depends. So if you look at firefighter studies involving CT scan, there was one study that showed that 35% of the active duty firefighters they evaluated that didn't have any symptoms coming in had evidence of this calcified plaque in their coronary vessels. And over half of them had 3 or more areas of plaque. So it was significant. This is the carotid ultrasound. And you probably had this. This is just a sound wave test. You had this a wand with the gel on it, and they rub it around your neck there. And they can find, oops, went too far there. They can actually see the plaque too. But this can pick up both the soft plaque and the calcified plaque. But it does one other thing. It can look at the thickening of the blood vessel too. And that's important. Remember I showed you that fatty streak in that one diagram? It can start picking up that you may not have plaque, but you're moving in the direction of development of plaque. In this particular instance, again, this is about $100. It's generally is, unless you have known disease, you'll have to pay out of pocket for something like this. But this is a very quick test, no radiation involved. So the third point is what we really found now when I talked to you about our study is that it's really those tests, those 2 tests that we talked about, that once we can actually look inside the firefighter to see if they have atherosclerosis and to detect that fatty plaque, it was what gave us really the more accurate picture, overall picture of an individual firefighter's cardiovascular disease risk. So what we did, and let me now talk about the pilot study. This was a pilot study. It was a small study. It was 50 individuals from both Baltimore County and Howard County. It was funded by the National Fallen Firefighter Foundation, male and female, 40 years of age or older. So this was our actual age range of the individuals in the study. They were all operational. None of them had known cardiovascular disease, never had an event. They didn't have diabetes. They had a current primary care provider, a current health insurance, and they had the agreement to have the communication of the information we found in what I call my triangle of information. They had the firefighter, they had us, and they had their primary care provider. So that's where the information went. And in fact, after each visit they would come to see us, a letter would go out to their primary care provider to indicate this is what we found, these are what we recommend. And what was good is this was a 6-month study. And over 6 months we saw the firefighters at baseline, 3 months and 6 months. And we were able to see their progress. We were able to talk to them and say, did you discuss the results with your primary care provider? Was the action we recommended taken? And it worked just beautifully. The whole system, that triangle of communication worked just beautifully for us. So before they ever came into the study, for their baseline visit, they had the 2 scans, they had blood work, they filled out a consent form, and then at the baseline visit, we did a physical exam. So we looked at their blood pressure and their waist circumference and their body mass index. We talked to them about their lifestyle, what their diet and exercise habits were, if they've been having troubles with their weight, and we ended up providing an individualized program of prevention for each firefighter, including lifestyle habits, including medication when required. And we also risk stratified them based on the results that we had. And of course, a letter went out to the primary care at that time. We followed up with phone calls in 1 month and 5 months, but we saw them again in 3 months, repeated the blood work and the physical exam. And we did the same thing again at 6 months, which was really very helpful because with the lifestyle changes that we'd recommended, they were able to see over a 6-month period, well, if I lost 3 pounds, look what happened to my blood pressure or my blood sugar. They could actually see progress, which was very powerful. And again, at the end, 6 months, a letter went to the primary care to show the recommendations overall. what we found in general was this. This is the risk factors we talked about earlier. But we found in general that of those 50 firefighters, half of them had blood sugar in the pre-diabetes range. That is between 100 and 126. That is, they were not diabetic, but they were moving in that direction. 48% were pre-hypertensive. And when we did this study, the high blood pressure guidelines were different than they are today. They've changed. And pre-hypertensive really means between a systolic blood pressure between 120 and 140. That's that top number. So they weren't hypertensive. They didn't have high blood pressure via the guidelines, but they were moving in that direction. 44% had high cholesterol, and 38% were overweight. So generally, this is a group that had risk factors that needed to be adjusted. In terms of that risk score that I told you about, 48 of the 50 were considered low risk. Only 2 of these firefighters were identified as high risk. And that's significant for us in terms of the study, in that this risk score really is driven very strongly by age. And as I said to you earlier, this is a very young population. Firefighters are a young population. So we're thinking that this may not be the best tool in our toolkit to utilize for firefighters because they're so young. And the reason we say that is because this is what we found when we actually looked inside. We found that 11 of the 50, or 22%, had plaque in their coronary vessels. All of them were male. 8 of them had more plaque than 75% of men in their age group. So in other words, they had above average amount of this plaque. 6 of them had plaque in more than 2 vessels, and 4 of them also had carotid plaque, which is not unexpected. If you have plaque in your coronaries, it's possible you can have it in your carotids as well. We didn't find really any significant association between having plaque and having cardiovascular disease risk factors that were not controlled. But it could be because our study was so small. It was only 50 individuals. And in terms of the carotid ultrasound, we found even more. 18 of the 50, or 36%, had plaque in these neck arteries. 1 was female, and 4 of the 18 had coronary plaque. And again, really no significance in terms of cardiovascular disease risk factors and having this plaque. And getting back to that risk score, remember I said only 2 of the 50 were considered high risk? So if we had stopped there, if we had just stopped at assessing their cardiovascular disease risk factors and looked at their risk score, we would have missed almost all of these individuals. And I think that is, for us, the main point. What we did for those firefighters that we found plaque, whether it was in the neck vessels, the heart vessels, or both, is in their letter to the primary care provider, we suggested a stress test if they hadn't had one. We suggested initiation of medication, aspirin and statin. Statin being important to help stabilize that plaque so that you don't get the rupture that I discussed. The aspirin to prevent the clots from forming on top of a plaque. And then, of course, we intensified lifestyle for them in terms of diet, exercise, and weight loss. So in general, what we found in the study was many of the firefighters in the study were overweight, they had high cholesterol, they were at risk for developing high blood pressure and diabetes, all significant cardiovascular disease risk factors. But only 2, through the risk score, were identified as high risk. And again, had we stopped there, we seriously would have missed the majority of those individuals who were at higher risk for cardiovascular event. So it was really looking inside with the coronary artery calcium scan and the carotid ultrasound, where we found, if we put the data all together, whether they had plaque here or both, 50% of the firefighters had plaque in some area. So had we not looked inside to evaluate the plaque, for plaque in the heart and the neck arteries, we would have missed nearly all of those that were at high risk. And missed the opportunity to, as I said, what our goal is to minimize their risk through minimizing cardiovascular disease risk factors. And that's exactly what we did for these individuals that we found plaque, is we said, okay, we're going to try to get all of your cardiovascular disease risk factors under control. Make sure your blood pressure's under control, your cholesterol's under control, that you're not going to become a diabetic, that you have good lifestyle habits and you're on the appropriate medications. And really, I think overall, just in a general sense, the lifestyle work that we did over this 6-month period, though not quantitative at this point, was good, because we found really a small percentage of the firefighters coming into the study really being optimal in both diet and exercise and weight. But by the end of the 6 months, we had 80% of them making a positive change somewhere. And that's because they had a plan. They walked out of the clinic with a plan. And that's a really important thing. All of this information now has been published in the American Journal of Cardiology, but also in a wonderful small article that the National Fallen Firefighter Foundation has helped us write in Fire Chief Magazine, and that's the link for it. So finally, the last point to remember is, so what do we do? What does all this mean? And I think the importance is that what we have to do is develop a team partnership between firefighters and their healthcare providers to be able to provide a comprehensive cardiovascular disease prevention approach, which involves evaluating cardiovascular disease risk factors, looking at their risk score, and possibly even looking to see if they have atherosclerosis. Because this is what is going to offer the best outcomes for firefighters in preventing and minimizing disease. So we know that reducing risk factors reduces risk for heart attack and stroke. We know that in the preventive medicine field. We know the values of the tests, the CT scans, the blood work that we do. We can actually identify, which we did in this small study, firefighters with heart disease and treat them. And we know that the cost of this treatment, detection and treatment, is really much less than the cost of disability and death. So as an example, cost-benefit analysis, knowing some data here that we received to give us some idea of what it would cost for permanent total disability and death benefit due to cardiovascular disease events, we can see that it's very expensive. And if you look at cost of CVD prevention, like coming to a visit to your primary care or to see us, most of this is covered by insurance. And as with the labs, it's, as I talked to you about, what I said, it's these tests that each of them cost about $100. So, if you take these numbers, you can see that you could actually screen 2,500 firefighters for the presence of plaque, for what it would cost for disability pay for one firefighter for 1 year. That's a lot of screening. And if our data is even close, that a third of those individuals could potentially have plaque here in the carotids, then we know that we could actually treat 900 of those 2,500. And I think that's the important point, because as I said, bringing it full circle, our goal in preventive medicine is to evaluate for risk and minimize risk. That's what we do. So finally, what can we do? This team partnership, because what we need to do is work together to develop a comprehensive program that can identify firefighters at risk through these risk factors and risk score and screening for atherosclerosis to help prevent and minimize disease, avoid disability and death, and really, the bottom line is offer the best outcomes for firefighters. So I've just gone over these 4 points, and these are our research partners. So I can open it up now to questions.
Actually, I have 2 quick questions. We keep saying, and I know the location here, we're talking about firefighters mostly. But when you look at those numbers and you look at the study that you did you have a control group, another group in that same age of police officers, accountants, office workers?
No.
To compare to say they have the same results? Because if it's firefighters are having this problem, what about other groups? I mean, are we that much on the other side of the fence, okay,
No.
as firefighters? And then the second part, that way you just got both of them. When you went through the risk factors, one of the things you talked about was smoking.
Yes.
A lot of our people also chew tobacco, cigars, things of that nature. Do you find tobacco in general the same, or is it the actual process of smoking?
Well, we know, I'll start with the last one. The actual process of smoking is a very significant cardiovascular disease risk. But we try to eliminate all forms of tobacco. So you're right, that should be just tobacco cessation.
Out of your 50, I didn't see any of them labeled as smokers.
None of them were. There were former smokers. And so then the question becomes, so when did they quit? 20 years ago, 10 days ago? Yeah. Oh, no, we found out about all the tobacco use, and there were individuals that had chewed in the past and smoked cigarettes in the past, but interestingly enough, none of them currently were smoking. And it's so interesting you ask that, because in my clinical practice, we hardly have any smokers. The problem is all the ones that were smokers stopped because they had the heart attacks or strokes like years back, So it's kind of an interesting thing. I don't have to deal with smoking or tobacco use very often at all, but it is a big problem. And especially if you see in younger individuals, and these e-cigarettes makes me very nervous, because I think it's a wrong pathway. So in terms of a comparison, no, there wasn't. We didn't do a comparison. It doesn't mean we can't do a comparison. Heart disease is the #1 killer in general for the population in the United States, for both men and women, which women don't tend to know. I think that the fact that is important for firefighters is it is the #1 killer, which goes back to one of the earliest slides. And I think that's where I'm coming into this, and that is that's just, there's no need to have that. If we can apply preventive tools to try to reduce risk and reduce the number of events that occur. Dr. Seaman, do you have a comment that you can add to that?
I would just say
controlled studies are the best way to look at clinical questions, but I think part of the motivation behind this was that we now have, probably 2-3 decades of data that cardiovascular disease is the #1 killer of firefighters, and we've not made inroads in reducing those numbers, basically. So I certainly applaud this effort, because I do think that to me, it's some of the first evidence that there's a program that can be effective at helping firefighters get healthier, have optimum health. And I think that really, to me, this is very similar to the new healthcare system. The new healthcare system is, how do we partner with patients so that they understand their diseases and can make choices that are best for their health? And I think similarly, this is for firefighters. When you ask the question about other groups, it's the #1 killer in the country as well. So I think that we find it in other groups as well, and I hope that they'll be addressed in this kind of new healthcare system coaching. But obviously, there are some unique things. We don't understand everything for firefighters, but perhaps being active later in their careers, the alarm bells, having an adrenaline surge. I think there was just a recent article, it was very interesting, that when you're under heat stress in turnout gear, it increases the stickiness of your blood. So how much does that affect it? We don't really know. We don't know all the factors, but there are other things about the profession and role of firefighting that seem to add to the risk, I guess is the best way to put it. So I think, to me, it was a wake-up call to say we shouldn't just continue to accept these numbers staying high, but do something about it, I guess.
Yeah, and I think, too, I want to make a point that it's not just about, let's rush out and get a CT scan or something. I think the most important thing is to have a program of prevention where you put all the pieces together. It's not piecemeal, because that's really not the best way to medically manage individuals that have atherosclerosis. And also, too, I think I've had questions from firefighters to say, well, I get my stress test, but keep in mind that by the time you would have a positive stress test, then problems have already developed too. So, trying to work early with individuals is really important. And so, going back to the beginning of the talk, this concept of looking at even the young firefighters and talking to young firefighters about way less than 40, about diet, exercise, detecting to see if any of them come in as young individuals with high cholesterol that may be genetically driven. So really identifying this, because how many young people really go to the doctor on a regular basis? They don't. So I think it's important, and I also think that it's important that to go back to one of the first slides, this concept of you guys are walking into these very high risk, extreme conditions, and if you have underlying disease, cardiovascular disease, then that makes it a much higher risk for you. You had a question.
Yeah. Once we start into this, the CT scan and the carotid scan, and you did this test group, did you go back and repeat the test and see if
Good
some
question.
of that plaque and whatever has reduced?
That's a really good question. We get this all the time from patients in our clinic. We don't repeat those tests. Those tests are tests to specifically risk stratify you. So in those individuals that we detected it, we're not going to go back again, because we're going to treat them very aggressively in terms of medication management and lifestyle to help minimize progression of their disease. Because people ask me this, can you get rid of the plaque? No, you can't go in there and rotor it out. They actually ask me, but you can't do that. But can you minimize progression of the disease? Yes. Can you help stabilize that plaque? Yes. Can you help minimize the clot formation? Yes. So you can do that, and that's what it's all about. So does that sort of answer your question there?
Yeah.
Okay.
So,
Did you? Yes.
okay. I hit all those risk factors, so I'm really nervous. I am, really. I guess my question is, so now that we've done this, is there a process now where we're going to, I guess, educate our personnel early on in their careers? I work here at the training academy, and through education and preventive
Right.
care, we reduce this number, hopefully.
Well, that's exactly right.
It's too late for me.
No, but it absolutely isn't. So that really does bring up the 2 points. Is one, that you have to start early, and as I say, you have to monitor blood pressure, cholesterol. I mean, you have to find out family history, because you could have a 30-year-old firefighter that has very high cholesterol that doesn't even know it. So things like that. But even lifestyle things, you cannot ignore that from the beginning. That's important. But then also when you think, oh, I have all those risk factors, too late for me, absolutely not. Absolutely not. Because we do this all the time. You can start now to make sure that your risk factors are under control, that your lifestyle is better, that if you're not exercising, you start to exercise. If you're not eating healthy, you can start that. If you want to lose 10 pounds, you can do that. It makes a huge difference to whether you develop high blood pressure, high cholesterol, and diabetes, which are direct risk factors for progression of cardiovascular disease. So it's not too late. Good, I'm glad. I don't want you to.
Can I make a comment
Yeah,
too?
oh, definitely.
So we are doing things at our department, asking our recruits to pledge to not smoke, to pledge to have fitness evaluation each year. Those kind of things are important. And then just to echo what Dominique is saying, and this is, I have not talked to Dominique about this, but there's a cardiologist out in San Francisco who has shown, I think fairly convincingly scientifically, that you can reverse heart disease. It depends on how radical you want to get, but if based on diet and activity and other things, you can actually reverse some of this atherosclerosis. So I think from that perspective, absolutely, I would say it's not too late. I would agree completely, and today's a great day to start.
And we always say, we put together lifestyle and medication management where appropriate. That is where the power comes, is you put those together. So.
In your study, just out of curiosity, because it kind of tags back to my original question
Sure.
about, is it just firefighters? In that study of 50, were they all on the career side of firefighters, or were
Yes.
any of them volunteers?
No, they were all career, and we did that on purpose.
Okay, I seem to remember being asked in an email who would want to participate in that. All of those participants, were they all, I want to do it, I will do it, or
Yes,
were
they were all
randomly
volunteers.
pulled?
They were all volunteers, yes. We received names, and I think I got maybe a little over 50, like 55. So, when I got to 50, I went through to make sure that they had not had any cardiovascular disease event or didn't have any diabetes. That's important. And then, said, yep, you're in the study, you're in the study. I just talked to them on the phone, and then, when I had 50, I stopped.
Has this been coupled up with, we understand the lifestyle of the firefighter and what they do. Has your study also been coupled up of what happens when they actually respond to the incident and the heart rate goes
Question.
up? Because Indianapolis did a study with Dr. Brown.
Uh-huh.
And I'm thinking if you're telling 50 people this is the baseline and you're not under any of the stress of the alarm, and then you couple that up with the other incidental things that Doc Brown did out in Indianapolis, is kind of just put us way over the scale of whatever you're looking at, especially like you said, the PPE and the blood thickening, all of these factors that go in.
This is an important question. So what we're doing is looking at how to actually identify and prevent. I'm very interested in the why. Why is this happening? What is causing that atherosclerosis to develop as it is in firefighters and increase their risk? And I don't know, but they're kind of, in the sense, it's a separate question. We did not address that, but it's certainly something that we, could do. But we didn't address that. We're addressing, do firefighters have cardiovascular disease that they don't know about, that we can treat? That's what we're after. Welcome. Yes.
Any more studies getting ready to kick off or being done?
Well, we're trying. We want it. It's an important question because we want to increase the N of this study. If this is only 50 people, but that's why I also showed that one study that they found 35% of their study the firefighters had plaque. So we're not really far off the mark here. But I think what we need is bigger numbers to be able to develop, to say this is the kind of prevention program that you need to instill in fire departments throughout the country.
Yes, ma'am. You had talked about the no smokers, and it took a while to get us to that no smoker point. And I think most of us that were smokers, we figured it out. And we didn't need a whole lot of tests to do that, but we needed the education that was the constant pressing of why you shouldn't. This test seems like it could be a good benchmark. And you said you don't check afterwards to see if it went away, but are you continuing with the 50 to see a year from now, if they've stuck to this, that they have slowed the progression down? Or is there any further thoughts of any additional testing? For those of us that were kind of thick-headed, that maybe didn't quit smoking when we should have, and we get this test initially and still don't change our habits, that we can see, ooh, you've increased your risk 50% more than we checked you a year ago. I mean, is it going to be a tool for that as well, or is this just a one-shot deal?
Well, as I say, we generally don't repeat these CT scans or carotid ultrasounds because we use them as a way to risk stratify an individual. But the question comes in, let's say you have that test as a 40-year-old and you get nothing on a CT scan, then it's likely maybe in 10 years you can repeat that. So that's something that you can do. And as far as working with individuals who are not changing their lifestyle, you just have to keep working with individuals along the way to keep reducing their risk through better lifestyle habits and medication management.
And hence, that's the weak link. because
is.
unless you keep repeating this and telling me, hey, idiot, you're getting closer
Right.
here,
I see what
you
you're
know, there's
saying.
no, I mean, this is science, and sometimes it takes science to tell us that.
Mm-hmm.
But if you're just going to do this one time, I'm going to say, just like when my wife tells me, you really shouldn't eat that, you know, you really need to go
Well, that's
check
why
on the
I
scale.
see people in my clinic over and over and over. I've seen some of my patients for 15 years. So, but that's what it takes. And so you're right. That is the weak link. First of all, if you don't go at all and identify your risk factors with, you know, your primary care provider, for instance, then you won't know. But if you don't keep going and keep working on these things over time, you're exactly right. It's a weak link.
One comment just I would make that in this new healthcare system as well, that's, you know, the goal is right to have lifelong health coaching in a sense.
A sense, yeah.
And I think that in this case, the primary care doctor can do that. So I think that you're absolutely right. This is about changing behavior. I think that when firefighters actually saw the plaque on the study, they said, instead of saying, geez, it doesn't affect me, it's somebody else, now they say it's me. So they change behavior, but you're right, it has to be followed up and continue to be. And I think probably that health coaching and reminding is probably the most important thing. The plaque develops over a decade, 2 decades, 3 decades, so it's not going to go away in 6 months. But I think the constant messaging, what you're talking about, is really going to be critical.